Good morning, everybody, and welcome to number 7 in the Early Intervention and Innovation Fund webinars. My name is Susie Hudson, and I am joining you from NADA, the Network of Alcohol and Other Drugs Agency, and we, in partnership with the Ministry of Health, and the funding has come via the Ministry to NADA members, specifically around innovative and inventive practices that have been going on in the sector. And this series is really an opportunity to showcase these brilliant projects and to share with you some of the learnings that you may be able to adapt into your service. I'd like to commence this webinar by acknowledging the traditional owners of the land on which we're all meeting today. We here at NADA are on Gadigal land as part of the Eora Nation, and I'd like to pay my respects to all elders past, present, and to future generations, and to acknowledge the massive contribution that Aboriginal people make, particularly in the alcohol and other drug sector, and to give a shout out to our Aboriginal workforce as well. So today's session, we are joined today by Associate Professor Peter Kelly from the University of Wollongong, and he will be talking with us about a particular project, which was a randomised controlled trial of continuing care via telephone intervention following residential substance treatment at the Salvation Army. And so at this moment, I'd like to hand over to Peter Kelly and invite him to share his camera. Thank you, Pete. And he will take away the presentation. Over to you, Pete.
Thank you so much, Susie. So hopefully everyone can see my slides now. And yeah, thanks for the introduction, Susie. So yeah, as Susie said, my name's Pete Kelly. I work at the School of Psychology at the University of Wollongong, and yeah, it's a pleasure to be presenting today on our continuing care project. Really just wanted to, I guess, begin by acknowledging the funding that we received to conduct this study. So this was funded by New South Wales Health and their Alcohol and Other Drugs Early Intervention Fund. I think this funding scheme, it was a funding scheme that I think was really targeted towards the NGO sector a few years back now. And I just think it was such an incredible initiative from New South Wales Health. I'm really hopeful that the findings of all of the projects and hopefully the findings of this research project are helpful and can help in improve outcomes and the way services are delivering interventions here in New South Wales. But I also think that this type of funding is just incredibly helpful for increasing both the kind of the research and evaluation capacity of the services and the NGO field more broadly. Provides really strong connections between universities and service providers. And likewise, and as you'll see as part of our team, it really helps to train the next generation of addiction researchers and addiction clinicians coming through. So big thank you to New South Wales Health for putting together an initiative like this. Likewise, really wanted to give a big thank you to the service providers that were involved as part of this research study. So the Salvation Army were the lead organisation for this project, and really wanted to give a big thank you to Mr. Jared Byrne, who was involved in fundamental in helping to develop this project, and ensure its successful rollout across and its ultimate success. A lot of it comes down to Jared. Jared is employed by the Salvation Army when we first started off this project, and more recently has moved over to We Help Ourselves. Likewise, big thank you to We Help Ourselves and Adele House who have been involved in this study. I think whenever we're conducting research, and even if the study is funded, it does put a level of burden on organisations and management and staff within those services. So a big thank you to everyone that was involved in helping to make this project a success. This is a pretty busy slide, and I'm still a little concerned that maybe I've left some names off there, and I sincerely hope that I haven't. But I just wanted to make the point, I'm here presenting really on behalf of a broader project team, and there were lots of people that were involved in this project at kind of all different levels. So there were lots of researchers who were involved in the study. Likewise, there are a number of students involved, particularly from the University of Wollongong. We had multiple universities involved. So Amanda Baker at the University of Newcastle. I'll be talking a lot about a telephone delivered intervention today that was, we often call the McKay protocol, and it was developed by Professor James or Jim McKay, who's based at the University of Pennsylvania. He was a really helpful and good colleague as part of this project. A lot of the work was based on his previous research. And then likewise, a big thank you to the Hunter Medical Research Institute, who helped to lead the stats and the economic analysis. And as I said, the services, and really just wanted to give a big thanks to the continuing care workers that were employed at those services, who did a great job. And as you'll see some of the results, they were able to deliver the intervention at an incredibly high standard. So big thank you to everyone involved. And just lastly, I promise I'll actually start this presentation soon. There's a number of students who have been doing PhDs or honours or master's projects associated with this work. I'll touch a little bit on some of Emma Hatton's work as part of this presentation, but there's a number of other papers and research findings that are coming out of this broader project that I just won't have a chance to touch on today, but we'll make sure we'll get presented at NADA conferences and the like. All right, so I should actually start the presentation. So this study, this continuing care project, is really based within residential treatment, and it's really based within non-government organisations. I think the logic behind conducting this project was this idea that, obviously residential programs do a really great job at providing treatment while people are in those residential facilities, but they're often not funded to conduct treatments, once people leave those residential settings. But we do know that, leaving a residential program is potentially a high risk proposition for some people. I think most people working in residential rehab have kind of always wished they could kind of provide some sort of ongoing care for people once they are transitioning from those residential facilities. I think likewise, and I think anyone that's worked in residential treatment knows that there's a bunch of people who do really well and just go on to thrive after residential treatment. But likewise, there's people that struggle once they're leaving these programs, and particularly people that might leave early or against advice. And so the idea of being able to provide some sort of ongoing care or ongoing support to those people, I think was it was a motivation for us, and I think the service providers as well in this study. And the third part is typically any sort of continuing care or any sort of aftercare that's provided as part of residential is typically, and kind of generalizing a little bit, but largely just focused on mutual aid. It turns out to be a really good thing, and you'll see some of the results talking about the importance of mutual aid a bit later in this presentation. But I think organisations have often had a desire to be a bit more proactive and be able to direct and provide some of the services themselves following residential treatment. In terms of continuing care, I think this is a term that most people are now familiar with, working across drug and alcohol treatment settings. But basically continuing care is this idea of extending a form of more intensive treatment with providing some sort of less intensive treatment. So if you think about a hospital system, you might go into hospital to have surgery on a leg. That's quite intensive surgery, lots of doctors and whatnot. And then you would step down to some other treatment. So you might have a telephone call from a nurse, or you might visit a physiotherapist or something like that. If you've got problems with your leg, if your leg's infected or the recovery's not going the way that's planned, they might step you back up into hospital, get that sorted, and then step you back down into lower intensive care. Same concept in drug and alcohol treatment. So moving from more intensive, acute type treatment within residential facilities, and then trying to step people down to some less intensive form, which might be mutual support, but might be sort of telephone counselling in this case. It's often referred to as aftercare here in Australia, and essentially the same thing, aftercare and continue care. But there's certainly a move to use the term continuing care, because it suggests that care doesn't sort of start and stop and start and stop. It's something that's progressive and is hopefully relatively seamless for participants. In terms of the broader literature, there's a number of reviews in the drug and alcohol field that show that providing continuing care is effective, and typically the longer you provide continuing care, the better the treatment outcomes for individuals. So our study and our project is largely focused on the work of Jim McKay. So if you have a look at his papers, he's got kind of a long series of papers really focused on reviews around continuing care in drug and alcohol treatment, and in particular, developing this telephone delivered continuing care intervention. So this book's available. I should have looked up the price before I started this presentation. I think you could find it on Amazon, so it's relatively cheap to buy, and it has all of the manual and the structure and how it is that you deliver the intervention, which we're going to talk about throughout today. So the telephone delivered continuing care, it's an evidence-based approach. There's strong sort of effectiveness findings in relation to the intervention, particularly in American settings, and particularly for people who are completing some form of intensive outpatient treatment. It's also been shown to be cost effective to deliver. SAMHSA, so the National Registry over in the United States, listed on their website as an evidence-based program and practice. So there's kind of a lot of support and a lot of work that's been conducted leading up to our study. In terms of the gaps, we weren't familiar with any research that had looked at it in terms of an Australian setting. And likewise, I don't think there was any work looking at it with people leaving therapeutic communities or residential programs. So I'm just going to go through this really kind of briefly, but I'm happy to answer questions around the actual intervention or send people sort of more detailed descriptions if that's helpful. Essentially, the telephone protocol, none of it's rocket science. And I think if there's any clinicians out there, drug and alcohol workers, if you're thinking about what you might want to do with someone over a telephone, after they've left residential treatment, it would probably be pretty similar to the protocol that McKay and colleagues have developed. So the idea behind this protocol is we contact people and we complete a session, which goes for about sort of 10 to 15 minutes, depending on how much there is to talk about. We look at their risk factors and we look at their protective factors. And in the protocol, there's some specific questions you ask around medical, mood, confidence, cravings, triggers, and likewise across the protective factors. You can score these. So ultimately, when you go through and ask these questions, you get a total, a number, and likewise you get a total and a number for protective factors. If people's risk factors are increasing and their protective factors are decreasing, it's suggesting that the person might be at risk of more negative outcomes. And likewise, if risk factors are decreasing and protective factors are increasing, that presumably people are moving in a positive direction. So we'd go through, check in, see how people are doing, also check on any substance use. And then the continuing care worker and then the participant would spend some time talking through the results of this and just helping to plan for the following week. So thinking about what goals or tasks they might want to achieve during that following week, and also thinking about how they might manage any high risk situations that might come up during that period of time. If people's risk factors are increasing and people's protective factors are decreasing, it also triggers this idea of stepping up to more intensive care. And so that might be conducting more telephone sessions with someone over that week period. But more often than not, it involves bringing the person back into the residential program and having a face-to-face session with them, trying to kind of get eyes on the person and help to kind of move forward. So what I'm going to try and do today, and we'll see how we go for time, whether or not we cover all of this, but the idea is to try and present some of the results from this kind of the main study that we conducted and some of the other sub-studies that we've conducted as part of this work. So really the main study was this, we conducted a big randomized control trial of the McKay delivered protocol. We've then conducted some sort of secondary analysis of the intervention, and I'll try and talk to that a little bit. We conducted a feasibility study where we delivered it as I'm not quite sure what the right word is. We keep using the word call center to deliver the continuing care intervention. So I'll talk to that and try and describe what that is and talk about some of the results. We also did a really interesting study where we did some interviews with the continuing care workers and the staff that were involved in providing some of the clinical supervision as part of that. And I think that provides some sort of direction for organizations and service providers looking to implement these types of strategies. So I'll kick it off with the with just talking about this main randomized control trial, this was really the main aspect of the study that we were funded to conduct. If you're interested, and you may not be interested, but if you are interested, we've published a protocol paper which really details, provides a lot of depth into how the study was designed and how the study was conducted. So I'm going to kind of breeze over it a little bit now, but if you do want the details, don't hesitate to email me and I can send you a copy of the paper. Likewise, the paper's open access, so you can just download it off the web. Essentially, this randomized control trial aimed to examine 3 different treatment conditions. So people were randomized into either a 12-session arm, where they completed 12 sessions or were offered to complete up to 12 sessions of the McKay protocol over a 3-month period. A 4-session arm, where people were offered to complete 4 sessions over a 1-month period after they left the residential program, and a control arm who didn't complete any of the telephone delivered sessions. I think as you're looking at the results, I'm really glad that we did include a control arm as part of this study. So in terms of the study design, I think as we've said, this study was really focused on the Salvation Army, and we helped ourselves. So we had Juralong and William Booth House, which were Salvo's sites. Both of those sites take both men and women. And then we work with 2 of the WHO sites. New Beginnings just works with women, and Gunya just focuses on men. We had continuing care workers employed to work on the trial. And I think what's really important, and I think potentially improves the generalizability of these results, is that those continuing care workers were physically recruited and employed by the services, were managed by the management at those services. And I think nearly all of the continuing care workers had been existing employees of those drug and alcohol services before transitioning over and working in this project while the study was going. I think nearly everyone. And then those continuing care workers completed some training. So I think it was about 4 days worth of training, both in the kind of research methodology and how to kind of complete the assessment measures type training, but also in the intervention and how to deliver the intervention. And then they were involved in fortnightly clinical supervision, which was kind of a really nice experience to be providing and being involved in that clinical supervision. We then had assessment officers who completed our outcome measures. The assessment officers had no idea what condition people were in, so they didn't know if they were allocated to 12 sessions or to the control condition. And they were all based at the University of Wollongong. And a huge thank you to that team. They did a really great job in terms of following up a really tricky cohort of people to follow up. In terms of the study outcomes, our main outcome focused on substance use. So we followed people up until 6 months. And what we were interested in looking at is in that sort of month prior to the 6-month follow-up, whether or not the number of days people had used during that time and the proportion of people that were abstinent at that time. We kind of tossed around a few different ideas in terms of, what's a sort of a sufficient primary outcome and whether or not abstinence is the right outcome. We ultimately settled on that because it's really the aim of the intervention, and it tends to be the aim of these residential programs is trying to promote at least a period of abstinence when people leave residential treatment. And if not complete abstinence, then reducing the number of days that people are using. So we looked at both the odds of complete abstinence, that's kind of a 2-step process, and then looked at those people who weren't completely abstinent, how many days of alcohol or other drug use did they engage in during that time. Then we also had just a range of secondary outcomes. So we looked at sort of patient-reported recovery outcomes using the SHORE. We sort of looked at psychological distress or mental health using the K10, quality of life, etc., etc. So there's a whole range of ones that I haven't listed here as well. We tried to use measures that were part of the database, and I'm not sure, presumably there's service providers potentially watching this who are using the database. You might be interested to look at some of the results of this study. You might be able to think about how that might compare to some of the longer term outcomes of your programs and benchmarking type activities, kind of 3-6 months after people have left your residential programs. In terms of the study flow for the study, I'm going to try and step you through this relatively simply. Hopefully you can keep this in your head because it's it's important for some other aspects of this presentation. But there were a number of steps. So the first step is the continuing care workers went out to the services and gave some presentations and let people know that we're conducting this study, that it involved doing continuing care. What was really encouraging is sort of 97%, I think it might even be slightly higher than that, of people reported that they were interested in being involved in the study, that were keen to be involved in continuing care. So it's definitely an interest amongst the population, which is great. We then ultimately screened 453 people for eligibility, 431 completed consent, and then we got down to 400 people who completed baseline assessment and the continuing care plans. The reason for the dropout in here is often we would approach and ask people if they're interested, and there'd be a delay from then to when we actually completed the consent and baseline procedures. And part of that is we just had one continuing care worker at the site. And likewise, at some of these facilities, I had really quite a large number of people. So it took a period of time to get through those assessment periods. We didn't follow up any of these participants if they hadn't completed the baseline and consent procedures. So often they'd left, more often than not, they'd left the residential facility. And it might have been a planned or unplanned discharge, but we didn't follow up any of these participants. But once we'd completed the baseline and consent procedures, we then subsequently followed up all of those people. So of this group of people, ultimately 277 people were randomized into either the 12 session, 4 session, or control condition. You can see the numbers. It's about 90 people per condition. It's pretty well balanced between the 3 conditions. We then did a 3-month follow-up and ultimately did a 6-month follow-up. We got about 77%, so 233 participants of the people that were randomized were able to follow up, which is great. It's such a difficult, challenging cohort to follow up. In many ways, well, largely people changed telephone numbers, they moved to different locations, etc., etc. We did kind of our very best in terms of collecting lots of alternate contact details, calling lots of times, and using email and Facebook and etc. But we're really quite pleased with those follow-up rates, and I think you can sort of put a level of faith in the results when you are getting sort of follow-up rates around that for this population group. In terms of the participants, we've collected tons of information, sort of descriptive information on the participants, and we'll kind of gradually keep publishing some of those results and try and present it at some conferences. But here's just a sample. So of the 277 people that were randomized, 42% were female, and obviously 42% isn't 50% of the sample. Still, we're kind of pleased with that. It's certainly much a higher percentage than we've ever got in previous residential rehab type research. I think New Beginnings at WHO's is probably a big factor in kind of increasing the proportion of females in the study. Average age was 38 years of age, which is about consistent with most rehab type research. 74% had attended mental health treatment at some stage in their life. So it sort of talks to that idea of the comorbidity and the complexity with this population group. On average, people stayed in the residential facility for 13 weeks. I should have said that for people to be eligible for the study, they needed to be in the program for at least 4 weeks. So we wanted them to sort of have a sort of sufficient dose of the residential program. So once they got to 4 weeks, then they were able to be recruited in the study. And so of those people, on average, they'd stay for about 13 weeks. So there's a bit of a range for those people. Smoking has really nothing to do with the study findings, and I won't mention it again, but just wanted to highlight 86% of the sample was smokers. 86%. I think in Australia, we're down to, 12 or 13% of the population who are regular smokers. We've barely made a dent, or if I'm not even sure we've made a dent in smoking rates in drug and alcohol treatment. We've certainly had lower percentages, but it's very rare that we've had higher percentages of smoking across studies we've conducted. We need to kind of keep it on the agenda. All right, so we start looking at some of the results from this study. So around like the fidelity to the protocol. For the 12 session arm, on average, we're able to complete about 5 sessions with the participants, so a little under half of the intended number of sessions. For the 4-session arm, we were able to get about sort of 2.5 sessions completed with participants. We recently sent some of these results through to Jim McKay, who's obviously done a lot of research in this area, and his comment around this was, it's broadly consistent with what we've found in other studies. We certainly never get it, 12 or full completion or anything like that, but it's probably on the lower end. And I'll kind of come back to this as a point a bit later on. In terms of actually delivering the treatment manual, we audio recorded all of the telephone sessions, and then we had independent people go through and rate whether or not specific aspects of the manual were being completed. And continuing care workers did a great job at that. So it was excellent fidelity in terms of what they were meant to be doing as per the manual and the protocol, and what was actually being doing on the phone. Which was great. Real credit to them. So in terms of the main outcomes and the main results of the study, I think something that was really kind of an interesting finding for residential rehabs more broadly, participants across all 3 study arms demonstrated significant improvements at the kind of 0.001 level. So there was kind of clear evidence in terms of the substance use outcomes that people were improving. And they were able to kind of maintain those improvements 6 months after they left the residential treatment, which is a really positive outcome for the salvos. And we help ourselves and presumably the other residential rehabs that are providing similar services. In terms of our main study question, we're interested in whether or not there was a significant difference between the 12-session arm, the 4-session arm, and the control arm. And we would have hypothesized that the 12-session, and we did hypothesize that the 12-session and 4-session arms would do better than the control arm, and potentially that the 12-session arm would do better than the 4-session arm. If we look at the odds ratios, those hypotheses were kind of, they look like that they were happening in terms of the odds ratios. So the 12-session arm, they were about 12, nearly, the odds of them being abstinent at 6 months was nearly sort of 12 to 13 times higher than what it was when people were first attending the residential treatment. Likewise, the odds are about 9.5 times for the 4-session arm and about 7 times for the control arm. So it's kind of happening in the right direction as what we'd hypothesized. However, and this is a little disappointing for the research team, is when we looked at whether or not there was a significant difference, so a difference that wasn't just due to chance, there wasn't a statistically significant difference between the 3 arms, which is kind of interesting, and I'll talk to that in a little bit. We looked at the secondary outcomes. So I need to explain this just a little bit. When we did the baseline assessments with people who were coming into the residential rehab, we didn't do those assessments like when they first started. We did those assessments after they'd been in treatment for at least 4 weeks, and sometimes 5, 6, 7 weeks after being in the rehab. So that's what we did for all of these secondary outcomes. And what we found was that, and we know, and if you look at some of the papers that have come out of the database, that people make pretty dramatic improvements in things like quality of life and mental health in those first 4 or 5 weeks in residential treatment. What we found was that participants across all of the arms, irrespective to which condition they're in, maintained these scores on these secondary outcomes. So whatever their score was on quality of life, about 4 or 5 weeks into treatment, they maintained that score on average when we're doing follow-up at 6 months. In theory, you wouldn't have been surprised if it had reduced a little bit. It's a bit easier to be in a residential facility where meals are provided and warm beds provided, and you're supported, and you've been there for a period of time compared to being out kind of in the real world. So we're really pleased to see just results being maintained across all of the treatment arms. However, in terms of this study, we didn't find any significant differences between the arms. So the outcomes look pretty similar across all 3 arms. Likewise, they all sort of maintain their improvements. So in terms of the discussion and some of the main points from this, look, it appears that the residential programs are having kind of quite a positive effect on people who are leaving these residential programs. So we're following people at 6 months, which is quite a long time in the scheme of recovery. They're certainly using less of alcohol and other drugs, and there's a The odds of them being abstinent at that time are much higher compared to how they were before they came into the residential programs. It looks like they're maintaining the improvements that they've been able to demonstrate while they're in the program. However, and really the main aim of the study is, does this sort of telephone delivered continuing care work? Because there isn't a statistically significant difference between the conditions, it doesn't really support rolling out this intervention across all drug and alcohol services. It's possible with an increased sort of sample size, we might have started to see some significant differences between abstinence at 6 months. I guess the trend was looking like it was going in the right way, but definitely want to kind of interpret those results with caution, and it's hard for it to really provide any level of strong evidence. What I suspect, and I'll try and talk about it in some of these remaining slides, is that this telephone delivered care is probably really suitable for a subgroup or a proportion of people, but isn't necessarily needed for all people who are leaving residential drug and alcohol treatment. So I'll now move on to some secondary analysis that we did around this group of participants in the main study, in this main randomized control study. This has been published, so if anyone wants a copy of the results of what I'm about to go through pretty quickly, feel free to email me and send it through. So if we go back to this flow chart, basically we had 400 people who completed consent baseline, and they all said, yes, I'm happy for you to call me after I leave rehab, and I'd like to participate in this study and hopefully complete continuing care. There were 9 people that we had to withdraw from the study, and that was just a result of COVID happening at the very tail end of the study and services changing the way that they delivered treatment. So we just made sure that continuing care was organised for those 9 people, and they'll just removed from the study. So basically, it was 391 people that were left, and we could randomise 270 people, or they consented to still being involved in continuing care. But then there was this other 114 people that we couldn't contact or decline to participate any further. And we're interested in whether or not we could predict the difference between these 2 people. I should add, and I probably already said it, but when we say we weren't able to contact these participants, we put in tons of resources, made lots of effort. While people were in the residential treatment, the continuing care workers would meet with them really regularly, check if contact details had changed, reminded them about this, talked about this idea that, sometimes people leave rehab under sort of unfortunate situations, but, still be involved in continuing care. We still think it's going to be helpful, et cetera, et cetera. So, and then once they left, we made multiple phone calls. A lot of energy went into it, is what I'm trying to say. So we were interested in who would consent, who would be willing to still be involved in continuing care after they left treatment, and who wouldn't. That was the first step. Then the second step is, of the people that were allocated to either the 4-session or 12-session arms, we're interested in who actually started continuing care. So these are the people who said, yes, I want to do it. But then there was still 38 people who we didn't ever able to complete another telephone session with them. So could we predict, or what's different between these 2 participants? Don't feel like you need to get too caught up in this slide. This is the first one when we're looking at who can we get on the phone after rehab and they say, yes, I'm still happy to be involved. We looked at a whole range of predictors, lots and lots of predictors. It was a very exploratory study. But what we found was that sort of marital status or relationship status, whether or not people were in a relationship, and loneliness, so their sort of perception of loneliness predicted whether or not they'd confirm consent. Indigenous people, so Aboriginal people, were much less likely to confirm consent or be contacted. And likewise, the completion of the service was all significant in the final model, and weeks in treatment seems important. So to kind of summarize this, it looks like the marital status and loneliness variables, there's some sort of level of social support. So people that are sort of have lower levels of social support are more likely to want to engage in continuing care after they leave. Likewise, sort of non-Indigenous people, and this idea of people who had completed treatment. If we looked at that smaller group who were randomized to either continuing care or not complete continuing care, completion of service was the main predictor. Age is kind of approaching, and years of regular substance use both appear important, but people that completed the service were more likely to engage. So in terms of discussion and some of the, I guess, the takeaway messages, continuing care absolutely appears more appealing for people with lower levels of social support and higher levels of loneliness. And that's absolutely what you would hypothesize, that it is kind of performing an important role for this group of people. There's a perception that continuing care might be helpful for people in this group. I don't think we did a great job in terms of engaging Indigenous people, and I think this is a whole new research study in itself around how continuing care should look, I guess, particularly in terms of Aboriginal community controlled organisations, and what are some of the best ways to deliver this. But clearly Indigenous people weren't that keen to engage in a telephone delivered continuing care as part of this study. Relatively small numbers as well. I think the other point is we really need to think about what happens to the people that don't complete treatment. We struggled to engage them, and you would presume that they're the group that's potentially going to have the more negative outcomes. Right, I feel like I'm flying through this. So now I wanted to move on to this idea of the feasibility study, or the call center study. So the McKay delivered telephone intervention is obviously a telephone intervention, but there's some face-to-face contact. So the initial session, you sit down and you complete this continuing care plan with them, and you see them face-to-face. Likewise, if people are ever off track, like their risk factors are increasing, you tend to arrange face-to-face appointments with the person. Likewise, in our study, we had the continuing care workers all employed at the services, and they saw the clients every day. So they could just say hello to them, remind them about the study all of the time. However, there's a problem with using this approach. It potentially reduces access to continuing care. And this was something that New South Wales Health specifically requested that we include as part of this study. Could we deliver the intervention without any face-to-face contact with participants? So we employed some continuing care workers who are based here at the University of Wollongong, and they did everything over the phone. And the aim was really to look at how feasible it was to deliver a call center model approach. I should say that the continuing care workers did work one-on-one with the same person over time. So it wasn't like people were getting called from a whole range of different people. There was consistency in the way it was delivered. It was really just that there wasn't any of the face-to-face contact. In terms of the methods were really similar between the main study and this feasibility study, except the continuing care workers were here in Wollongong, and everything was delivered over the phone. We used different study sites to avoid any kind of level of contamination. So Salvo's down in Canberra, Adele House had a couple of sites at Wellington and Coffs Harbour during the study period, and the Cessnock we help ourselves site as well. And a big thanks to particularly the management and the staff that were helping to lead the projects at those sites. I won't go into the results in a heck of a lot of detail, but just wanted to point out that, so when we did the study, if we're looking at interest, so in terms of feasibility, you're really interested in, can you do it? Is this possible? Can it happen? In terms of level of interest, it was about the same between the main study and the feasibility study. People in general said, yeah, this sounds good. I'm happy to be involved. I think the major kind of most significant finding of this study is when people left, and we ultimately tried to get them on the phone within that 2-week window after they left residential treatment, we're able to get about 70% of the people on the phone from the main study. We're only able to get about 30% of the people on the phone in the feasibility study. And you would have to assume that that's a result of relationship and getting to know the continuing care workers and being much more likely to accept that telephone call and be involved. In terms of other results, really similar between the main study and the feasibility study. So the number of sessions was about the same between the two different study approaches. In terms of how well the continuing care workers delivered the intervention or completed any of the sessions, all non-significant, pretty similar between the two groups. So in terms of conclusions, I've kind of underlined the word relatively. It's absolutely feasible to deliver the continuing care sessions without any in-person contact. So once you can get the person on the phone, you can typically engage them in a similar way, and they're willing to do it. But the challenge is actually engaging people after they leave the residential treatment. So it's really quite a dramatic difference between the percentage of people that we could get between the two different studies. So in terms of a call center to model, there's probably some benefit to it, and you can certainly get a proportion of people through it, but there's a cost associated with how many people you can engage after that. I'll just touch on this study just really briefly. So we've got a doctoral student, Emma Hatton, who's really interested in looking at outcome trajectories for people who are accessing residential treatment. I think what we're interested in here is just doing some kind of secondary analysis and trying to understand, so irrespective of the randomized controlled trials that were happening, we know that when we followed people up at 6 months, some people were doing really well. They had sort of a high level of recovery, and other people weren't doing so well, and they had like a lower level of recovery. And we're interested in, can we predict whether or not people are going to be in the high group or the lower group? And so we used a regression analysis to do that. A bit like some of those other studies that we did, we included just a whole range of predictor variables to try and understand whether or not people are in this high category or low category. So we did a lot of work, very exploratory. Ultimately, what we found is what best predicted whether or not people had high recovery or low recovery at 6 months was if they had alcohol or amphetamines as their primary substance of concern, which, by the way, is the two most commonly identified primary substance of concern during the time that we did the study period. But the other bit was attendance at mutual support groups. So the people who are still going to mutual support groups in that 3-month period before we did the 6-month follow-up, that predicted whether or not people were in high levels of recovery or lower levels of recovery. You've kind of got the chicken or egg thing. Are they going to mutual support because they're doing well, or is the mutual support helping them to do well, et cetera, et cetera? So kind of take the finding as with a grain of salt, but it's suggesting that the mutual support is playing sort of a potentially important and protective role for people. It's mostly Alcoholics Anonymous, Narcotics Anonymous, but likewise people attending Smart Recovery as well. I should say that this was an aspect that's really encouraged as part of the McKay telephone protocol. Just finally, I wanted to talk about this last study. So it's the qualitative study that we did. And I think often qualitative studies are what provide kind of the most interesting information in terms of guiding, like understanding why interventions work or don't work, and thinking through how you can actually implement it. This paper has been submitted for publication. We're just addressing some minor comments at the moment. Have just resubmitted it. So hopefully this paper will be accepted for publication kind of reasonably soon. In terms of the aims of the study, so we did interviews with continuing care workers. All of the continuing care workers agreed, which was great. We also interviewed the people that were providing the clinical supervision and were listening to all of the audio sessions. We thought they might be able to provide kind of a unique perspective. And then they were interested in looking at sort of the successes and challenges associated with the intervention, and also trying to provide some recommendations for service providers. We're going to skip over the methods just for time's sake, but it was a qualitative approach that we used. So in terms of the findings and perceived successes and challenges, kind of all of these things had successes and challenges. So for example, telephone delivery. Continuing care workers were very vocal in sort of talking about the strengths of telephone delivery. It's flexible, can reach clients who don't live close to the rehab. You can get people after hours, et cetera, et cetera. But there's absolutely some challenges with telephone care. So establishing rapport, and particularly the workers at the call center sort of discuss some of the tricky parts associated with establishing rapport via the telephone without ever seeing people face to face. And it's also kind of hard to read people. I should say we didn't use Zoom or Skype or anything in this study. It seems like a weird thing to say, but the technology just didn't feel like it was there at the beginning of this study, just the sort of the uptake of using these approaches within the services, but also once people left. It's probably a different story now as a result of COVID, and maybe it would change some of the results, but it's something that we didn't use at the time. In terms of the manualized program, I think most of the continuing care workers were really quite positive and spoke about how it was kind of clear and a sensible structure, and it was quite an easy thing to follow. I think when we're doing the training, often the continuing care workers would kind of look at it and be like, oh, this is too much. But once we'd done some training and people had completed the sessions, it tended to work pretty well. And I think that talks to it being trialed so many times overseas and presumably refined. But continuing care workers likewise made some suggestions on how things could be improved. So, for example, providing a bigger focus on values might be part of it. There's a big focus on particularly 12-step approaches, and having a sponsor as part of that, which is clearly really important for some people, but maybe not so important for others. So I don't know, maybe there's some tweaking of the manual, but overall looked pretty good. In terms of the attributes of the continuing care workers, just being authentic, good counselling skills, confident in delivery, honest, mutual desire to succeed. This idea that you're kind of really working with the person in a non-judgmental way was really important. This idea of being really proactive in the follow-ups and not just waiting for the client to make a call, or calling once, and if it didn't work, just calling back a week later, calling a few times, sending text messages, being flexible is really important. In terms of recommendations, and there's more recommendations in the paper which people can read if they're interested. From an organizational perspective, I think one of the main parts is just really prioritizing continuing care as just a core aspect of the treatment. So it's tricky when you're sort of trying to integrate a research study as part of an organization, but you don't want continuing care to be something that's kind of separate. Ideally, you want it to be integrated with the themes and the approaches that are important as part of continuing care. It's really important that continuing care workers are trained and have regular access to supervision. And I think one of the main parts, and probably the takeaway messages around this, is just this idea of tailoring continuing care to the individual. So considering the kind of unique needs and preferences of people, and listening to what the people who are involved in continuing care kind of consider and prefer. So in terms of just some overall conclusions, we didn't find significant differences between the treatment arms, and I just suggest caution in terms of like any wide scale dissemination. I think that there's a proportion of people who really value being involved in these types of calls. I think there's a proportion of people who just make a decision not to be involved in these calls. And I think maybe thinking through how we can provide probably more sort of patient-centered care and think about individual person preferences is important. The call center approach, as we said, it works, but there's the kind of the major risk that you lose a bunch of people from when they leave the residential treatment to when you get them. I think some future work needs to kind of think about people that drop out early and how we might be able to provide a safety net for those people, and absolutely considering how we could address it in a better way for Indigenous people, Aboriginal people accessing these services. I think is important. So I might leave it there. Thanks everyone for listening to that, and I'll throw it back to you, Susie.
Thanks so much. That was amazing, Pete. Lots of content there. And I suppose too, I'll really encourage people to get in touch, about the research findings and some of the papers. I think that's really useful. I've got a couple of questions, and we have got a few questions on through the Q&A box, and I'd really encourage anybody who has a question to pop it either in the chat or the Q&A, and I will attend to those as we go. I'm curious, Pete, you talked about obviously that potential dropout, and I wondered about, are there any learnings for, obviously they've gone from that intensive person-to-person contact in the resi and then out to phone calls. I'm just wondering whether there are any lessons to learn from, say, our current phone line. So that is people who contact ADIS, the Alcohol and Drug Information Service. Given that people have reached out via phone, could there be some benefit that could be reached there if they were getting follow-up calls or sort of more assertive follow-up?
Yeah, I can give you a few different answers. So we had very assertive follow-up procedures and practices. And I think what we learned from that is just because people had dropped off didn't mean that they didn't like the intervention. I think like they'd moved into other residential programs, or they'd picked up other forms of treatment, or they were just doing really well and it was hard to do these calls while they were back at work. Or so I think because people are dropping off, I don't think we should assume it's because they're doing poorly, or more often than not, they're getting into other forms of care or kind of moving on with. So I think they're good things. I've never worked at Addis or I had much to do with them, but absolutely our experience was you needed to make multiple telephone calls, and you needed to send text messages and messages through social networks, and people appreciated that. You let them know that they're the strategies that you're going to be using, and people generally appreciated that. So if you're just making one call, I think you're going to have a very low hit rate in terms of following up people. But if you're a bit more proactive, then you can often get people. And then just accepting that not everyone wants or needs this intervention at this point in time.
Yeah, I mean, I certainly found working at the stimulant treatment program, we did a lot of assertive follow-up using text, and people found that very reassuring. They wouldn't necessarily have to touch back or have a phone call, but it was certainly very, very useful. I'm going to turn to some of the questions here, and Catherine Brake has asked, can you explain more what you mean by statistical significant results for continuing care telehealth? 12 sessions of 4 sessions and control, what would it have looked like if it was more statistically significant?
Yeah, I'll give my best go at answering this. So when you're doing any research, potentially you can get findings that are just by chance. And so we use this idea of statistical significance to say, look, this isn't, or hopefully this isn't part of chance. This is a meaningful difference. And so what we found between those 3 conditions, although it looks like that there's differences, there's still a chance that it's as a result of chance, if that makes sense. So if you think about it, just a threshold of sort of saying, look, if it's above this, we'll say, yes, this worked. That if it's below this, we can't say that it's going to work. Our results didn't get above that line. So the best way to think about sort of medication, like think about vaccines, you want to have a level of confidence that COVID vaccines are going to work, and you want it to be above a sort of a pre-designated threshold. Ours was just under that pre-designated threshold. It looks promising, but it's it's the frustrations with research. And
just to add to that, Pete, clinically significant changes are also slightly different again.
Yeah, so the study that was, I didn't really get into the detail, but the study that Emma Hatton was looking at, it's looking at people who had made enough change on those measures that you would say, yes, that's clinically meaningful. So it's not that they're just moving like 1 or 2 points on a K10. It's that they're moving 10 points on a K10, and if clinicians look at it, they'd be like, yes, that's a clinically meaningful difference. And these are important concepts to kind of think about when you're trying to interpret information.
Yeah, I think you're right. Another question, were you able to compare baseline characteristics of those who engaged with call centre continuing care versus those who did not? So I think you talked a little bit about that in terms of their social connectedness and the loneliness aspects. Were there any other particular things that you can comment on about the differences?
So we haven't done it as part of the call center study, but we did do it as part of the main study. And yeah, none of those demographic variables or how well people are traveling on different sort of outcome, NADA-COMS type outcome measures were significant. It was the social relationship aspect, loneliness, and I think it was weeks in treatment and Indigenous status were the variables that were significant. They were different between the people that engaged and didn't.
Because of the virtual care, what people are finding in some of their virtual care through the COVID period has been that for some particular groups and for some Aboriginal and Torres Strait Islander people, yeah, that phone support wasn't perhaps as connected. We also heard from DAMEC that for a lot of people from culturally and linguistically diverse backgrounds, it wasn't as sort of taken up, or it didn't have people engaged as much.
Yeah.
Another question for you. Do you think and that sort of follows on from this idea of the COVID stuff, is do you think it would have had a positive impact if Zoom or Skype had been used rather than the telephone, just purely the telephone?
I can see that question from Andy. I don't know. It just seems bizarre that we didn't use it. Now, you know, we're doing all of these things on Zoom, but really the technology and the infrastructure just didn't exist at the start of the study. So look, if we were redesigning the study right now, we probably would have had, would have been doing sort of our initial assessments with people a bit like I'm talking to you right now. Potentially, yeah, I would presume that it would, but don't know for sure.
And another question from Fadil, is it reasonable to say that even treatment as usual group received some treatment by virtue of being called to participate in the research or be engaged in the research?
Yeah, so I give a couple of answers to that. I didn't really cover it as part of this presentation, but everyone, while they were still in rehab, the continuing care workers sat down with them and completed a continuing care plan with participants, so that everyone had this 1 hour session and they completed a plan and were given a copy of it. And so they're provided with kind of that level of intervention. And then just by very virtue of conducting assessments with people, you're kind of monitoring people, which is an intervention in itself. My hunch, and not even hunch, I think it's sort of replicated in some of the findings that I haven't presented. I think the people that were in the control condition went to other treatments. I think they went to mutual support, or they went to specialist outpatient drug and alcohol services, et cetera, et cetera. So it's not like they weren't getting any continuing care. I think by virtue of how the rehabs work, of engaging people in 12-step programs and smart recovery, that they were still getting other forms of treatment. Which is great. Like that's what you want happening as part of these residential rehabs. The telephone sessions is maybe a trend, but significantly didn't seem that made a bigger difference in terms of those outcomes for those participants.
And one last question from me, Pete, which is a little bit off kilter, but I think it relates a little bit to what Fadil is talking about. I'm really curious to know, that idea of the actual sessions that were being provided, being audio recorded and being sort of reviewed, if you like. My sense is that it's quite patchy across our practice sometimes, that we know back in the day, and I'm sure you may recall, there were many times that people used to sit in and observe your therapeutic interventions with clients, or you used to perhaps record sessions and then review them later on for the purposes of good practice. And I just wonder, did you get any sense from the participants, the people delivering the sessions, that was of use to them in terms of developing their skills?
Yeah, so I'm probably a little bit biased in terms, like I was delivering a lot of the training. I'll just throw that out. But look, I think it was incredible. I hope it was incredibly valuable for the continuing care workers. I think when we started the training, they had quite low confidence in terms of delivering this protocol and this manual. They'd never seen it before. And it was a pleasure to see them kind of go through the training, did practice sessions, and to listen to their sessions, and for their fidelity to be so high. I think it was a relatively straightforward manual that people could learn the process. And then I think they brought with them their own kind of clinical skills and life experiences and all of that, which kind of helped to make it shine. So yeah, and I think I'm speaking to the converted here, Susie, but I think like clinical supervision and providing opportunities for people to review their own sessions and listen to it, and learn from peers. I think that their skills dramatically increased, particularly around the intervention. I hope.
Yeah, look, thank you so much, Pete, and thanks everybody for joining us. If you have further questions for Pete, please send them through and we'll happily link you up. This intervention is really important, and I think it just goes to that fact of needing to provide that ongoing care for people, that treatment doesn't end, that there are options for people. And just by instituting a program like this, where you've actually got processes in place and you're monitoring how things are going, I think that automatically really improves people's practice and ultimately the impact on the client group as well. So thank you so much, Pete, for joining us today. And thank you all for joining us. We really appreciate it. And do stay tuned. The next on the list will be episode 8 of our webinar series. And it will be looking at the efficacy of specialist long-term community-based AOD outreach supporting people leaving prison. So please do join us for that. Thanks again to everybody and have a great Friday. Bye.
Thank you. See you later.